Thank you all for attending. Today we're having as a guest Dr. Mohammad Sabbagh. He's a PGY3 neurology resident at University of Kansas Medical Center and of course a graduate of University of Jordan ما شاء الله عليه. والده بيكون دكتور قصي صباغ كلكم تعرفوه the neurosurgeon. Uh, he's going to give us a semi-structured discussion more or less about what it means to be a neurologist. Uh, what's your day-to-day life going to be, uh, the fellowships, the path. وهو لحاله ما شاء الله عليه. He's very accomplished. He does research, and currently, if I'm correct, a candidate for the stroke fellowship, right?
Yep, yeah, I'm applying for a stroke now.
Yes, I think we covered that. If you would like to start,
Okay, yeah, thank you, Ali, for this introduction. So nice to meet you all, first of all. So لما علي حكى لي يعني what like yeah we want a presentation about neurology, like I was thinking what are the core things that we want to cover today. ف شفت انه احنا exposure in the medical school is lacking a couple of things, منها انه what is the like what would neurology encompass as a field, like as a neurologist شو بيعمل neurologist. الشغله الثانيه اللي هي what are the subspecialties available within neurology و the path towards neurology. So this session will be kind of divided into 3 different sections. السكشن الاول راح يكون just an introduction, what is neurology وشو role of neurologist بالinpatient والoutpatient setting, how neurology is different from other specialties that are really close to it like psychiatry, neurosurgery, and internal medicine. طبعا يعني I'll give a brief introduction and then I'll يعني اتوقع it's better than just giving it like as passive presentation انه تكون discussion. انا بس راح احط سلايد وبعدين نبلش احنا نحكي. Second session اللي هي the pathway towards being a neurologist. I'll talk about the 2 different models of like neurology as a fellowship or as a separate residency. وسبيسيفيك راح احكي عن United States يعني الماتش process. والثird part راح يكون brief overview about the subspecialties of neurology. I'll give like one liner about each one and I'll open questions for them. So to start first, the first section is what is a neurologist? So as simple as it gets, a neurologist is a medical provider who treats nervous system pathologies in a non-surgical manner. And لما نحكي nervous system معناها central nervous system and peripheral nervous system. في big part of neurology which is neuromuscular medicine or peripheral nervous system neurology. It's almost more than half of neurology. This is mainly managed and treated by neurologists. الشغلة المهمة إنه how neurology is distinct from other specialties. So yeah, neurology overlaps with neurosurgery. It overlaps with psychiatry as well. But there is a difference. زمان يعني كنت أنا أفكر إنه neurologists mainly do the medical management for neurosurgical diseases ونeurosurgeons بيعملوا surgery, which is true to an extent. بس لازم تحطوا ببالكم إنه there are some diseases that are like purely diagnosed and treated by neurologists, and there are some diseases that are purely diagnosed and managed by neurosurgeons. Unfortunately, our exposure, at least in medical school, يعني خريج جامعة, كان إنه الneurologist هو بس non-surgical aspects of neurology, which is true to some extent. But like for example, neurosurgeons, like لما نطلع على كل neurological diseases, neurosurgeons they are managing 3 major parts of neurology, which is trauma, tumors, and bleeds. These are the major parts that are managed primarily by neurosurgeons. We as neurologists, we have a role in that. Like we can diagnose these, we can do some medical management, but like if there is a trauma patient, me as a neurologist, I might recommend management of intracranial pressure, blood pressure, but the rest is surgical. Same with brain bleeds, same with tumors. Anything else in neurology is primarily managed and treated by neurologists. This is the way to think about it. So there are like some aspects of neurology that we've never been exposed to in medical school. So for example, strokes. So everything in a stroke except the last step, which is intervention, is managed by neurologists, and even the intervention sometimes is managed by neurologists. Then we have epilepsy. Like 90% of epilepsy is pure neurology. We have movement disorders, neuromuscular disorders, dementia, headache disorders, demyelinating disorders, and brain inflammation. So all of these are purely neurological diseases, and these are very specific for neurologists, which means that the role of neurosurgeon is little here. However, yes, sometimes we need them. Sometimes we consult them for that. The other difference between neurology and neurosurgery, most of the time, neurologists are involved in the neuro investigations and neurodiagnostics. Whenever there is a diagnostic puzzle, like a patient is having personality changes and seizures or so, they might end up having something surgically treated. I know they might have a brain tumor or something weird going on, or like a hemiencephalitis that's refractory to treatment, and we'll do epilepsy surgery for this patient. But the whole diagnostic process and the decision making is mainly made by neurologists. On the other way around, neurosurgeons will diagnose and treat the trauma patients, brain bleeds, tumors, and they will help diagnose some of our patients as well. Some of our patients will present initially to neurosurgery, and then they will see the patient. Nope, this is not a surgical patient. This is a brain inflammation. They will send the patient to us. They might also treat some of our refractory patients as last line of treatment. So this is the difference between neurosurgery and neurology. Psychiatry and neurology, I'd say neurology is really close to psychiatry. We diagnose a lot of psychiatric disorders. A lot of neurological disorders will present with psychiatric diseases. And a lot of our patients would have a functional or psychiatric overlay. So neurologists should be really good in psychiatry. Again, the main difference is we don't treat the pure psychiatric disease like schizophrenia or bipolar disease or borderline personality disorder. But apart from that, depression and anxiety, psychosis, especially in Parkinson patients or dementia patients, we treat most of the time. And we do a lot of motivational speaking, counseling, some initiation of cognitive behavior therapy is done by neurologists. Because keep in your mind, almost half of neurology patients, 25 to 50%, are what we call functional neurological disorders, or not an organic disorder. It's more of psychogenic, something that can't be explained medically, and we usually diagnose them and initiate the treatment before sending them to psychiatrists or so. So there is an overlap with psychiatry, and neurology also overlaps with internal medicine. I'll emphasize on that more in the subspecialties, but specifically stroke and neurocritical care are really close to internal medicine. But overall, the bread and butter cases for neurology are stroke, seizures, headache, and dementia. In the outpatient setting, seizures and headaches are the most common things that we see, like paroxysmal neurological disorders. Episodic disorders are almost half of what we see in the clinic. In the hospital, it's mainly strokes. I think, I gave my introduction about what is neurology. Now, if anyone has a question about neurology, what is neurology? What is the role of neurology? What is the future? We can open it for questions now.
في حدا عنده سؤال؟ اوكي. I think we can
دكتور
move on.
سؤال شو طيب أشياء مثلا زي نيورو سايكايتري أو إشي زي هيك، هل تعتبر جزء من نيورولوجي أو تعتبر بس أكاديميك أو إنها سب سبيشاليتي تخصص لحال؟
So neuropsychiatry, so there is no specific specialty called neuropsychiatry. هي كان اختلاف بالنaming. في branch of neurology called neurobehavioral or cognitive, which is purely dementia. It's a fellowship out of neurology. الشغله الثانيه في شيء اسمه neuropsychology, which is more of a PhD. Neuropsychologists usually do the neuropsych testing to diagnose dementia and memory problems. It's a PhD. It's like a high, more than a clinical. It's more of research, learning how to do these screening tests. Some programs have a combined neurology and psychiatry program, and the provider will be kind of boarded in both neurology and psychiatry. So there are like multiple pathways, but it's purely neurology. I'd say يعني اذا واحد بيصير neuropsychiatry بس انت بدك تفكر فيها انه هل انت بدك تكون mainly cognitive testing و management of memory و dementia. This is part of neurology. This is neurocognitive or dementia specialty. الشغله الثانيه اذا انت interested بال more of doing the tests وقصص personality disorders وهالشغلات, هاي more of neuropsychology, just doing tests and screens and counseling your patients, which is a PhD. If you want to practice both, you can do a combined residency neuropsychiatry. I think في pathway ما أعرف, أنا أتوقع psychiatrists can do also an extra year or be specialized like that. The other thing, yeah, بس في شغله كانه our time is up. الميتنج راح يخلص after 10 minutes.
في 5 دقائق. if you want اول ما نخلص هي السكشن نسوي واحد جديد.
تمام. اوكي.
I actually هون عندي question قبل ما نكمل. How much خلينا نحكي مش exposure بس how much do you work with pediatric neurologists basically, and I think the bread and butter cases of pediatric neurology definitely has to be different, right?
Yeah. So pediatric neurology, at least in the United States, it's a separate residency. So there's adult neurology and pediatric neurology, but there is an overlap. So pediatric neurology resident will spend 1 year with us. 1 year out of 5 years of pediatric neurology is with adult neurology, and we spend 3 months with them. We share a lot of cases. So like bread and butter cases for pediatric neurology, especially like seizures, developmental delay, pediatric strokes. I think, yeah, we feel comfortable treating these as adult neurologists. And pediatric neurologists are really good in managing adult things as well. They spend the whole year with us. The main difference is, so pediatric neurology is they deal a lot with developmental delay things. They deal with epilepsy even more than us. Epilepsy in pediatrics is very complex, and they have a lot of epilepsy syndromes and like things that are refractory to treatment. They also deal with the NICU patients, neonatal ICU, the hypoxic ischemic injury, counseling families, managing the brain damage to these patients. And they have a lot of movement disorders, even more than us. So they treat a lot of cerebral palsies, dyskinesias, dystonias. Part of neurology is movement disorders, even adult neurology, but it's less compared to pediatric neurology. These are the main differences, but they are technically the same specialty. Like, yeah, I'm not a pediatric neurologist, but like if there is a bread and butter case of pediatric neurology, I feel comfortable dealing with it because it's still neurology. But yeah, kids are not small adults, so there are definitely some differences there. Any other questions?
فينا نحول اللينك هلا because we only have 4 minutes left.
Yeah, خلينا نحول اللينك.
او خلي حدا هلا يجهز اللينك.
يس، هو راح يكون نفس اللينك، بس راح ارجع اعمل يعني a new meeting.
اوكي. خلينا نكمل. اوكي، خلينا نكمل هالسكشن. Maybe it will take a couple of minutes. The second misconception about neurology is that ليش الناس ما بروح neurology؟ لأنه most of our patients are chronic and they are progressive. Their neurological diseases will get worse over time وما في شيء نعمله. Which is partially true, I'd say. The third thing is a lot of our patients are very needy. They have a lot of psychiatric comorbidities. They have a lot of what we call convergent disorder, non-neurological symptoms. These things are partially true, but keep in your mind. So first of all, in medicine, technically, we never cure any disease. Like, صح, في بعض diseases, the outcomes are more satisfactory, but we never cure anything. Medicine is more, بشكل عام الطب كله, is more about making people functional and giving them a comfortable life, giving them dignity. Neurology puts more emphasis on this compared to others. Neurology is purely diagnostic. This is the first like fruitful part of neurology, having like the right diagnosis. The second part is, for most of our slowly progressive chronic diseases, we can change the life of our patients. Yeah, we're not going to cure the disease, but a Parkinson patient can live like 10 to 15 extra years of his life بشكل كأنه طبيعي if was managed appropriately by medicines. Epilepsy patients, even if it's refractory epilepsy, if we can get their seizures to like at least 1 seizure a month compared to like 5 seizures a day, there's a big difference. بالنسبة إنه yeah, our patients are needy or they have a lot of psychiatric comorbidities, this is so satisfactory to be the only one who kind of be able to appropriately diagnose the patient and give them the comfort and counsel them that how to deal with their non-neurological symptoms. I'd say بدنا تروح لجروبات الدكاتره بالاردن الشعب الاردني ما يسال بتلاقوا كثير سيمتومز غريبه انه انا ما اروح قلت ل 10 دكاتره وايدي ما بتتحرك ومش عارف ايش وكلهم ما بيفهموا. yeah probably الدكاتره كلهم صح هي مع المريض ما عنده شيء بس في مشكله في جاب بالكوميونيكيشن سكيلز كيف انت تقنع المريض بالدايجنوستس وكيف يصير احسن. these functional disorders will get better if you can give them the diagnosis and if they trust you. فهي شغله كثير fruitful بالنيورولوجي يعني حتى لو عندك كثير مرضى نيدي if you build a relationship with them كثير بتحسن وكثير يعني شيء satisfactory يعني بيكون شافوا 10 دكاتره شافوا دكاتره كثير يعني pioneers بالفيلد وما تحسنوا بالاخر بيشوفوا if you are able to convey a diagnosis to them they will be satisfied. Also, the misconception in our days are incurable is changing. For example, the biggest example is stroke. 30 years ago, stroke patients' treatment was mainly secondary prevention with aspirin and rehab. Now we have more research and we have more protocolized ways to reverse the damage by TPA, thrombolytic, and endovascular treatment. And even post-stroke, we have a lot of advances in rehab. We have advances in secondary stroke workup where can know why the stroke happened and how can we prevent future strokes. For example, stroke 30 years ago كانت يعني خلص ما لها علاج. هسه أكثر شيء بالنيورو satisfactory. فاحنا وين وقفنا؟ كنا بنحكي عن حكينا introduction عن neurology, what is neurology, what neurologists do. We stopped انه general impression للناس انه مشكلة with neurological disorders that they are chronic and progressive, and we gave some examples of advances in neurology, for example stroke. The other two big fields in neurology that they had a lot of advances are movement disorders. For example, for Parkinson's disease, you diagnose your patient is getting worse, but you can give them like 10 or 15 years of like يعني بيعيشوا زي إنسان بيكون functional, they have dignity just by adjusting their medications. So even then, if all medications fail, we have a lot of advances in like deep brain stimulation and brain surgery for that. Same with epilepsy. Now we have a lot of medicines for epilepsy. Plus, we have epilepsy surgery, VNS, neuromodulation. Now, epilepsy surgery and movement disorder surgery, they are done primarily by neurosurgeons, but you need the neurologist to make the decision and to do the mapping and instructions. And a lot of time, the neurologist will be in the OR with the neurosurgeon kind of guiding them because at the end, these are his patients. And like the VNS programming, DBS programming is usually done by the neurologist rather than the neurosurgeon. فيا في كثير اشياء بالنيورولوجي قاعده تتغير وتتطور والاوتكمز كثير قاعده تصير احسن. The last part and like definition of neurology is the different styles of neurology job. Overall, neurology is divided into inpatient or acute neurology and outpatient neurology. And they are two different settings. They are completely different. They overlap, but like the lifestyle, the type of patients that you see are different. The old model for neurology was that the neurologist, and some places that are still doing the old model. مثلا مستشفى الجامعة لسه احنا عندنا old model تاع neurology practice انه هو النيورولوجيست بيكون عنده كلينيك بيشوف مرضى بالعيادة وبيكون في مرضى ادميتد على اسمه بلف عليهم راوند ذا افترنون. اغلب الاماكن اللي لسه على الاولد موديل شوي كمان صار فيها تغيير. اللي صار انه ايش؟ انه even if the neurologist covering inpatient and outpatient, النيورولوجيست بيكون بالعياده الصبح، بالافترنون ما بيكون مرضى ادميتد على اسم النيورولوجيست، بيكون ادميتد على اسم الهوسبيتالست او internal medicine والنيورولوجيست will be following as a consult. هي بالسم كوميونتي هوسبيتالز واغلب الاماكن. مستشفى الجامعه اتوقع لساتهم على الاولد موديل اللي كثير قديم اللي هو لا they have their own primary patients. المشكله بتصير وين؟ اذا النيورولوجيست working both inpatient and outpatient. مرضى الانبيشنت بيكونوا سك مرات، ولازم واحد يكون يعني موجود طول الوقت عندهم. ف it's hard to manage both clinic و your primary patient in the hospital. بس بشكل عام اغلب الاماكن باليونايتد ستيتس واغلب يعني حتى باوروبا خلص صار انه يا انت اوت بيشنت او ان بيشنت نيورولوجيست، او مثلا بتكون اسبوع بيورلي ان بيشنت، اسبوع بيورلي اوت بيشنت. الانبيشنت نيورولوجي يعني انا بحب كثير inpatient neurology from my standpoint. You see the acute neurology, you see the acute decompensating patients. Most of your patients are sick. The outcomes are amazing بالinpatient neurology. You save their lives. It overlaps with internal medicine and neurosurgery a lot بالinpatient setting. المشكلة إنه mistakes are fatal بالinpatients. يعني a lot of patients might die in front of your eyes if you made like not even a wrong decision, if you were late in your decision for a couple of minutes. The most common inpatient stuff that we see seizures, and by the way, inpatient neurology also encompasses emergency neurology. So if there is a neurology patient coming to the ER, غالبا المقيم او اخصائي الطوارئ هو اللي بيشوف المريض بالاول، بس اذا في شيء بعيد عن الاساسيات اللي هم بيعرفوها they will call neurologist. فالinpatient neurology كمان بغطي الطوارئ most of the time. common things اللي بنشوفها بالinpatient seizures، بنشوف مش يعني one time seizure، لأن the seizure is not an emergency by itself. بس patients with complex epilepsy, patients with like cluster of seizures, patients with status epilepticus. and treatment of status epilepticus is يعني كثير حلو، كثير يعني فيها thought process, kind of adjusting seizure medicines with dosing, which requires deep understanding of pharmacokinetics. The second thing is stroke. 50% of inpatients is stroke, I'd say. Most of the stroke management is inpatient. The rest of the stroke management is either done by general neurologists. Sometimes rehab or like internal medicine can do the outpatient management. It's not a big deal. مشكلة الستروك هي الacute phase. For most of the actual stroke care happens in the hospital. So if you're interested in stroke, most of your time will be in the hospital. Also, acute inflammatory and debilitating diseases like Guillain-Barré syndrome. A lot of these patients will be very sick. They will require intubation. Neuromuscular disorders like myasthenia gravis, ALS, exacerbations, they might be also admitted to the hospital. Then we see a lot of perioperative complications, either before surgery or during surgery. We had a couple of patients who had stroke in surgery, inside the surgery, especially brain surgery. So neurologists and patient neurologists have to come and kind of make the decision what to do. And then encephalitis is a big part as well, specifically autoimmune encephalitis. At least based on my personal experience, autoimmune encephalitis nowadays in the United States is way more common than infectious encephalitis. And this is an interesting field. Autoimmune encephalitis is a bizarre disease. It's hard to kind of diagnose and think about it if you are not like in the right mindset and you are not exposed to it. يعني مريض الاوتوميون انسفلايتس لما ينشاف ما يعني اذا واحد مش نيورولوجيست صعب اصلا يستوعب شو هالشغله. مش قصه theoretical background او دراسه او knowledge، بس ما في exposure. الاوتوميون انسفلايتس is kind of disease either يعني if there is no neurologist in the hospital ما حد اتوقع راح يشخصه او يعالجه هالمريض. كثير من المرضى هذول الايديوباثيك اللي يعني كنا نشوفهم بالميديكال سكول اغلبهم بيطلع عندهم autoimmune encephalitis which is easily treatable if diagnosed appropriately. The neuroimmunology and neuroencephalitis is like a very interesting field of inpatient neurology. Then we have the outpatient neurology. Most of the outpatient neurology patients are headache and epilepsy patients. Outpatient neurologists will also see like longitudinal follow-up for Parkinson's disease, myasthenia, dementia, and post-stroke care. I'd say post-stroke care, like it's not almost always done by neurologists. In some models, the prime PCB or the internal medicine doctor can do the post-hospitalization care because like it's straightforward and easy and so protocolized once the patient's outside the hospital. The other differences between inpatient and outpatient. The inpatient neurology على الاقل على الموديل تاع اليونايتد ستيتس انا بحكي، ما بحكي عن بالاردن غالبا في اوفرلاب بغطي كلينيك وين بيشنتس. اذا كان واحد نيور هوسبيتاليست السكادجول تاعه بيكون 7 days a week on 7 days a week off وبيكون مغطي 24 hours 7. يعني بيجي على المستشفى بلف راوند على المرضى بيكون اون كول على التليفون مده اسبوع بعدين باخذ next week off most of the time. الاوت بيشنت السكادجول تاعهم بيكون موستلي زي اي شغل شو يسموه زي شغل حكومي، وظيفه حكوميه. بيجي على 8 أو 9 بروح على 4، 5 أيام بالأسبوع، ويكندز أوف. المشكله الاساسيه بالاوت بيشنت اللي هي اول شيء اتس هارد تو جيت ثينكس دان. لما اغلب مرضى النيورو بدهم كثير ورك اب يعني ولونجيتيودينال فولو اب، ولما يكون مريض انت مش موجود عندك ما بتقدر تعمل كل شيء، ما بتقدر تجبر المريض تعال اعمل MRI مش عارف ايش. اغلب المرضى they will lose follow up. بالinpatients لا، you have the patient, you do everything and then you fix it, send them home. المشكله الثانيه البيبر وورك. لما تكون انت اوت بيشنت you have a lot of paperwork to fill وديسابيليتي وانشورنس. كمان البوست اورز. you as a outpatient neurologist مثلا عندك let's see the 2000 patients that you are following. اي neurological problem with your patients they will call you. يعني اي مشكله patient messages والكولز كثيره بالاوتبيشنت neurology. most of our patients are needy وعندهم كثير symptoms they need management. مثلا الباركنسون patients او هانتنجتون patients you are technically their primary. يعني اذا انت عندك مريض باركنسون البرايمري تاعهم ما راح يمسك الادويه. اذا بده يبلش اني بايوتيك برن عليه. ليش؟ لانه they don't feel comfortable with it. or MS for example multiple sclerosis. if multiple sclerosis patient gets pregnant انت مبدئيا انت الاو بي جي واين تاع الام اس patient. يعني لان هم يعني اوكي الاو بي جي واين they might do the simple things but كل شيء له علاقه بالبريجنسي انت المسؤول عنه. فهي مشكله الاوت patients. some people would like it انه انت يعني you really know your patient, you are building relationships with them. If you are this kind of person, outpatients for you. Otherwise, inpatients more of acute medicine. All right. So, any questions so far about what is neurology, or should we start now with the pathway towards neurology residency? أي واحد عنده
عندي سؤال.
Yeah.
يعني مثلا ما في يعني what's the rate of يعني success مثلا واحد يفتح outpatient؟ عشان انت حكيت انه اوكي في كتير loss of follow-up وهيك and they have to follow up a lot of patients. يعني you can't مثلا يعني double fellowship تساوي او تجيب كمان واحد هيك and just cover headache, sleep and seizures مثلا we just
No,
open
not
a center.
really. Yeah. لا هسه الشغله ما في لا مش قصدي في كثير loss of follow up. اغلب النيورولوجي patients they stick with us لسبب بسيط. يعني لانه اغلب النيورولوجي patients they have like their symptoms are disabling. يعني حتى الهيدك as simple as gets انت الشخص الوحيد اللي you treated their headache فراح يضل يجي عندك. المشكله مش اللوس فولو اب، المشكله انت you don't have control on the outside world. يعني مثلا بدك تعمل مثلا مريض الام اس تاعك بده MRI كل سنه وكل 6 شهور، ما في شيء بضمن لك المريض عمل ورك اب. كثير بتصير انه انت يعني تحط تيست وايمجينج ويو ويل سي البيشنت 6 months، تيجي 6 months المريض ما عمل شيء. فهي قصدي انه you don't have control over the over their like on the outside world. بس as a loss of follow up لا يعني I'd say the drop rate maybe 20%. 80% of patients will stay with us. بالعكس لأنه still a lot of neurological diseases the patients they don't feel comfortable with anyone unless it's their neurologist. يعني الام اس patients بيسالوك على كل شيء، المايستينيا patients على كل شيء، اي دواء بياخذوه بيسالوك. فيا لك السكسس ريت عالي. يعني الاوت بيشنت neurology practice is usually busy. يعني بيكون عندك at least 2000 3000 patients you are following regularly.
ممتاز.
Okay. Other questions about neurology? Okay, I think we can start the next section. The next section اللي هو pathway toward neurology. أتوقع هالsection should be more interactive لأنه ما في شيء كثير نحكي. فشو what questions do you have about neurology residency, how to apply to the match, and the pathways to become a neurologist? إذا أي واحد عنده سؤال عن البروسيس هاي. We can give this. Yeah, we can maybe give it 10 minutes. Yeah, the whole 10 minutes for this
Floor is
section.
yours. في حدا عنده أسئلة؟
أسألك هلا إيش الجينيريك كريكولم للنيورولوجي ريزيدنسي باليو اس؟
Perfect. That's the next slide. Okay. So there are two models for neurology residency. Some places, not in the United States, أغلبها I think أوروبا وجزء من الدول العربية. النيورولوجي هو عبارة عن fellowship out of internal medicine. المشكلة بهالموديل أولاً you are spending 4 or 5 years of your life doing pure internal medicine. مع إنه to be fair, to know the bread and butter things in internal medicine 1 year is more than enough. يعني انت سنه واحده yes you can manage acute internal medicine, you can manage internal medicine floor, you can be a hospitalist. المشكله الثانيه انه when you spend 4 or 5 years of internal medicine doing couple of years of fellowship like ما بعرف يعني ما راح يكون عندك المايند سيت والاكسبوجر to learn neurology. فالموديل القديم انه النيورولوجي part of internal medicine اغلب الدول خلاص يعني they are shifting to the new model اللي هو هسه باليونايتد ستيتس. باليونايتد ستيتس neurology is a separate residency, it's a separate specialty, which is true. It's very very different from internal medicine. We do 1 year of internship, which is like first year is 90% internal medicine. You are technically an internal medicine in the first year. It's a purely inpatient. You don't get any clinic in the first year. Medicine residents will have a clinic. You don't have a clinic. So you learn hospital medicine, which is really good if you want to be a neurohospitalist. You know how to manage like common things, blood pressure, diabetes. You know how to even like basics of how to recognize like hematological emergencies, how to manage acute kidney injury, how to when to send patient to dialysis, manage antibiotics. These are important skills for any hospitalist, anyone working at the hospital. Yeah, so this is the first year. You might have some neurology exposure in the first year, but it's like maximum of 6 weeks. Between first and second year, most of the programs will have like a couple of days to weeks of transition, give you like a boot camp. They will kind of teach you more about neurology. And second year is the most important year for neurologists. As a neurologist, the second year is like, yeah, like you learn 90% of neurology in the second year. Usually it's very intense. You have like a lot of night shift. You have a lot of inpatients in the second year. Again, depending on the structure of the program, some programs would say second year is inpatient, third and fourth are outpatient. But unfortunately, يعني هي مشكلة بالأغلب البروجرامز بالUnited States. Most of the residencies nowadays are inpatients. Like we get a little, like very little of outpatient exposure, unfortunately. And this is like a nationwide problem. بس يعني إذا بنطلع على السكادجول, second year, I'd say at least 9 out of 12 months are purely inpatients. You do stroke, you do general neurology, you do epilepsy, you do nights. You have a lot of night shifts in second year. Once you are done with second year, I'd say by the end of second year, you'll be like a senior. You'll be technically like almost an attending. Like 90% of neurology, you'll be fine with it. Third and fourth year, it's more of refining your knowledge, learning how to manage complex cases, plus getting more of an outpatient exposure. Again, depending on the program, some programs will do like third year purely outpatient, but it's getting less common. And fourth year is a mixture. In between these, third and fourth year, you have some additional outside rotations. So you do psychiatry, at least 1 month of psychiatry. You do at least 1 month of ICU. Some programs would have like 6 months of ICU, but it's like from one to 6 months, depending on the program. And it's a neuro ICU, should be neuro ICU. Then you should do at least 3 months of pediatric neurology. You should do at least 2 weeks of pathology and 2 weeks of radiology. These are spread in third and fourth year. Now الشغله اللي كنت احكي عنها انه ما في كثير outpatient exposure. When I say outpatient exposure انا قصدي انه like specialty clinic. بس الشيء الحلو بالسيستم تاع United States, starting from second year, you should have your own clinic. So you have your own clinic, you have your own patients, you have so half a day a week. So like يعني 4 ساعات بالاسبوع. You are seeing your patients. So بغض النظر عن الروتيشن تاعتك, عندك كل اسبوع 4 ساعات you have your own continuing clinic, seeing your own patients. فيعني حتى لو انت ما كان عندك any outpatient exposure, يعني ما عندك outpatient, ما عندك مثلا شهرين dedicated for outpatient, انت at least مره بالاسبوع قاعد بتشوف your own patient doing longitudinal follow-up. So I'd say يعني regardless of the model of the program, you will be fine with managing outpatients like bread and butter cases. But depending on the background of your training, some programs you will be like really good in outpatient. Like you'll be ready to work as a general neurologist. Some programs are the opposite. Like at least KU our program, like we get really good in stroke and epilepsy management in the hospital. We have good exposure to outpatient, but I think we need kind of more training in that. بس بشكل عام الستراكشر تاع النيورو انه it's 1 year medicine, 3 years neuro, السكند ثينج اللي هي ممكن هاي السؤال كثير بسأل عنه what's the difference between advanced and categorical program of neurology خصوصا إذا حد هسه بده يقدم على الماتش. There is not a big difference, honestly. Difference is the categorical program you apply to the match and you match in the program for the whole 5 years. يعني المقعد السنة الأولى تاع internal medicine مضمون. يعني مثلا KU is categorical. KU اللي هي Kansas University is a categorical program. When I matched بشكل تلقائي سنة أولى I signed a contract with internal medicine. هم يعني it's a granted spot. بس خلص هالسنة I started neurology. Advanced residency programs they will give you the 3 years only, so you match 2 years ahead. But you have to like you have it's like a combined match. You have to apply to prelim years alone, or you have to apply to advanced spots alone. وبعدين like you need to find a 10 minutes and spot by yourself. Most of the time it's easy. The prelim year is not super competitive. It's easy to get it. بس شويه ريسك الشغله يعني what if you matched in an advanced program بعدين ما لقيت prelim spot خلص بروح عليك السبوت. So these are the two models of neurology match. In terms of how competitive it is, it's not super competitive. It's kind of similar to internal medicine, I'd say. The only thing is they really want someone to be dedicated. هي شغله بين نيورو لانهم البروجرام دايركتورز بيعرفوا انه في ناس بيقدموا نيورو as a backup. The CV تاعتك واضحه انه neurology is a backup, they will never send you an interview. They want someone who's interested. And neurology is a field where like if you're not interested you can't work in neurology. It's different. Like internal medicine ماشي, it's general medicine. We learned it in medical school, شويه training and you can live with internal medicine حتى لو انت ما بتحبها. بس neuro if you don't like neurology, if you're not dedicated to neurology, you can't يعني خلص ما بتقدر تكمل residency, ما بتقدر تكون neurologist لأنه شوي different from other specialties. So they look for someone who is really dedicated to neurology, someone who's like their CV is mainly around neurology, someone who worked with neurologists in the past. فهي perfect candidate to neurology residency. تمام. What other questions about neurology residency or the match process for neurology?
هون أنا هلأ كنت بدي أسألك قبل ما before you move forward. طب شو التقسيمة خلينا نحكي مثلا which one is more common الكاتيجوريكال طبعا صح أكثر من الادفانسد.
Yeah, 90% of programs are categorical. I interviewed in only advanced programs, and to be fair, advanced programs يعني MGH Harvard is advanced, Tufts is advanced, Yale is advanced. فهذول البيج names أغلبهم advanced. بس المشكلة it's risky. يعني I interviewed in some advanced programs and I ranked only one of them. مع إنه أغلبهم مناح. بس it's risky. يعني we are IMGs وإذا راحت السنة خلاص يعني we consider unmatched. but I'd say like 80 to 90% of programs are categorical.
Okay. So أصلا يعني هم أصلا the more common أصلا أنت يعني برأيك you'd recommend all of us to apply to a categorical residence.
Yeah. Okay. Yeah. وشغلة ثانية احنا as IMGs شوية الفيزا situation لازم we have to renew the visa والأشياء. As إذا رحت على advanced programs you are technically going to 2 different programs. فالvisa process the first year is different from the second year. But you have to start over in the second year. بس the fourth year it's categorical programs it's easy. You do the process in the first year and then you move forward. Like every single year you just copy paste the same documents. That's it. But advanced لا, you need different documents for the first year and the rest of the residency. So even it's much easier as categorical.
تمام.
وشغله لاحظتها انه لما تكون انت like prelim in your program they will treat you differently, like even your residents, because you know you will be their colleague, you'll be maybe their senior neurology resident in a couple of years, they will be working with you. يعني بيحترموك اكثر ما تكون انت prelim. لانه حتى in our programs كان prelims for anesthesia I think كان they're gonna work on another program for the rest of the residency. ما بعرف يعني طريقه تعاملهم كانت شوي مختلفه معهم لانه يا انت بس يعني you're here with يعني انت more of a trainee rather than a colleague. Any questions in the match process?
أنا حاب أسأل إنه يعني قديش بحس الريسك إذا الواحد كانت السي في تبعته مش كلها toward neurology يعني للماتش. إنه يعني إذا قدمت مثلا neurology and pediatrics قديش بيكون أضعف الموضوع إنه وكان نفس الإشي الإكسبيرينس تبعتي both of them
هسه as a CV ما اتوقع كثير يعني ما اتوقع كثير تفرق اذا واحد عنده more exposure to more than one specialty لانه يعني I've been asked this question in the past لان شوي انا كان عندي research psychiatry internal medicine and I told them like I was a medical student يعني I was exploring فهم they are totally fine with it right someone is exploring فطبيعي انه يكون عنده شويه research باكثر من specialties شارك بكم من campaign or interest group مختلفات عامل electives اكثر من specialty بس at least show them that you were considering neurology you did something in neurology you did an elective in neurology at least 1 month your letter of recommendations are written at least by 1 or 2 neurologists الشغله الثانيه اللي هم they can catch it اللي هي ال personal statement بعرف ناس they applied to internal medicine and neurology but they played it smart انه السي في تاعهم كان mixed neurology and internal medicine they wrote 2 personal statements one for neurology and one for internal medicine هيك ممكن تمشي يعني اذا الواحد شوي شاطر بطريقه صياغه السي في والبيرسونال ستيتمنت ممكن تمشي الامور بس اذا واحد يعني purely internal medicine و suddenly applied for neurology this is like a big red flag.
أو كمان كم غالبا يعني كل programs كم letters of recommendation غالبا بيطلبوا؟
Most of them will ask for 3 maximum على الويب سايت هو 4 صراحه يعني it's a 3 to 4 the classification our split of letter of recommendations usually what I did is one from a neurologist from my home country غالبا بدهم حد من medical school هي it's essential فأنا جبتها من neurologist من عندنا من medical school وحطيت واحدة من neurologist باليونايتد ستيتس وحطيت واحدة من cardiologist باليونايتد ستيتس that's it I submit only 3 letters of recommendation في ناس بيعمل submission ل 4 this is totally fine but keep in your mind maximum is 4 يعني الموقع أصلا ما بيخليك تعمل assign more than 4 but it's not about the quantity I'd say if there's someone who's gonna write you a really good letter of recommendation keep it الأولوية ليكون US trained someone you work with in the US it's better to be a neurologist but it's not a must بس يعني السبليت أنا بحكي إنه يكون at least one تكون من United States ويفضل تكون neurologist at least one من الأردن من الميديكال سكول يفضل تكون neurologist plus another one it's better to be in the United States and it's better to be from other specialty from my own experience just to see that you are a team player and you can adapt like yeah you work with other specialties and they like you as well بس ما في general rule بس يعني أنا بشكل عام my advice إنه تكون at least واحدة مش neurology منهم إذا كانوا 3 تكون واحدة one neurology أو مش neurology أو 4 تكون واحدة مش neurology but it's totally
يعني
fine.
yeah. أوكي يعني هي ضروري مثلا يكون واحدة من الأردن مثلا إنه
yeah they will ask أغلب programs they will ask إنه يكون chairman of your neurology department.
أنا هون عندي سؤال طب وإذا النيورولوجي ديبارتمنت بجامعتي مش منين؟
some people so it depends on the person so إذا النيورولوجي ديبارتمنت بالأردن قبل يكتب لك letter of recommendation في ناس بيكون خلص يعني بيحكوا لك انت اكتبها write it yourself خلص انت write it yourself و make them sign it هي يعني golden opportunity.
أنا راح أحكي لك هم التنين اللي عندنا هيك this is what's gonna happen it's important for
ممتاز بالضبط ممتاز أنا ممتازة.
actually أنا رحت سألت قبل ما كنت عم بقدم فكنت بدي واحدة من عنا من الموجود هلا حكى لي اكتبيها بوقع لك إياها بس أنا ما عملتها يعني قلت خلص ما بداعي.
ممتاز هيك يعني you write a really good letter of recommendation و you submit it. إذا ما نفعت you can play it إنه إحنا ما عندنا neurology department هي part of internal medicine في chair of internal medicine وبكتب لي إياها. في ناس هيك بيعملوا.
أنا هون عندي follow up question بعد إذنك. هلا we have a lot of students me included طبعا كمان we do our electives طبعا أو شيء هيك أو كل شغلنا بيكون مع neurosurgery أوكي أو يمكن anesthesia مش necessarily another internal medicine specialty. Is that better than internal medicine letter ولا is it equivalent ولا زي neurology ولا كيف? What do you think?
It's same. I'd say neurosurgery and anesthesia they work closely with us. It's same. يعني internal medicine, neurosurgery, pediatric, anesthesia letters are technically the same. يعني the same value. They will give them the perspective that you are a team player. You are still interested in neurology and you are exploring fields قريبة من neurology for them.
Okay.
يعني حتى anesthesia is very close لأنه neuro ICU is usually run by anesthesiologists.
بالضبط.
They work with us.
بالضبط. Do you see any benefit on submitting a fourth letter of recommendation?
If the program says so, if the program says that you need only 3 letters, there's no benefit from it.
Okay.
But yeah, if you have like whole maximum 4, I'd say. Some programs will ask for 4, some programs will ask for 3. إذا بدك تريح راسك submit 4 for everyone. I did this for the fellowship. يعني أنا fellowship ما كنت فاضي. I submit 4 for everyone. ما قعدت أشوف مين بده 3 ومين بده 4.
فهمتك. Okay.
بدي أسألك إذا في هلا هو I think the meeting it will finish in 2 minutes بس قبل ما يخلص بدي أسألك إذا في skills معينة إنه it helps to match أو إنه practical skills نحكي حتى إنه لو مثلا analysis research skills أو إشي معين.
Yeah. Again, it depends on the residency program. Some programs are more research heavy and they look for researchers. بس الشغل يعني mindset خصوصا بالresidency. Residency is a clinical residency. So having a research background is good. But they usually look for certain personal characteristics, and there's the goal for from the interview, having an interview. So when you're doing the interview, they want to see that you are a team player, you are someone who's ready to learn, someone who's adaptable and flexible. These are the 3 most important skills that you need to show, and you need to shape your CV and personal statement about these. وبالمقابل يعني they will ask some questions just to tease these things out. ف yeah, high important skills. هسه added skills, definitely having research background, doing research is important. The more they have research, the high likelihood of getting better interviews. إذا والله بتعرف تعمل statistical analysis و you know how to do meta analyses, you attended some workshops in neurology, this is great. This will increase your chances. But like بالآخر يعني يعني مش هم هالأشياء هم بدوروا عليها. بالآخر هم they are looking for a resident, for a colleague that they will work with for 4 years. فبركزوا أكثر على personal characteristics والinterest in neurology, I'd say. بس هم هالاشياء وين بتساعد in getting an interview. يعني مثلا big names, university hospitals overall. اذا واحد ما عنده research background يعني هي red flag. لانه most of the time university hospitals you will work in research. نفس الشيء مثلا البيج مثلا هارفارد وييل وهذول الايفي ليج. They need someone who's really involved in the community, someone who kind of worked in campaigns, helped people, helped in education, publish a lot of research. هاي اشياء بتساعد ان واحد يحصل على المقابله. But once you get the interview, then you are all equal. والديفرنس الوحيد هو your performance in the interview, like your goals, your perspective to neurology. وريمبر بالاخر شوي هي المايند سيت مختلفه. بالاردن احنا بنحس انه ريزيدنسي هي جوب. يعني البروجرامز they are waiting from you انه بتعرف تعمل سكيلز، بتعرف تعمل سحبات دم، بتعرف تعمل ال بي. هون لا، they want to teach you. فانت لما تيجي هم بتوقعوا انت ما تعرف شيء. they are not waiting, especially like الهاند سكيلز ما بتوقعوا مثلا تعرف تعمل suturing او ال بي او central line. They will teach you if needed. Sometimes you will never need it. So like what's the point from teaching it to you? Here it is. أي واحد عنده more questions about the match process?
في ميرامار. Yes.
بدي أغلبك بس بسؤال. أنت حكيت لنا إنه يفضل إنه يكون في letter of recommendation من النيورولوجي و letter of recommendation من department تاني. هل يفضل إنه هذا الديبارتمنت يكون باليو اس اي؟ يعني قصدي إنه أدور على 2 month neurology experience in neurology elective ولا 1 month neurology و 1 month إشي تاني عشان أخذ letter of recommendation بإشي تاني يعني.
I'd say تكون mixed experience أحسن. يعني أنا هيك عملت والأغلب هيك بيعمل. يعني 1 month of neurology, another month of something else. But again, it's totally fine. إذا يعني واحد ما له إلا 2 months of neurology, it's totally fine.
تمام.
يعني it's not a must. بس أنا شفت يعني some programs they prefer إن تكون another letter of recommendation from another specialist.
شكرا كثير.
Okay. Other questions?
يعطيك العافية دكتور.
الله يعافيك.
بدي أسأل بالنسبة للإلكتيفز، كيف ممكن الواحد إنه يعني طريقة يحصل إلكتيف برا أو بالمستشفيات، يعني ما يتواصل، إيش يبعث، متى يبعث مثلا، متى أحسن وقت؟ شكرا.
Yeah. صراحه الالكتيف مشكله صراحه، يعني حتى انا على وقتي انا ما قدرت احصل الالكتيف الا من عن طريق الجامعه اللي هو فاندربلت. وعلى وقتنا كانت لسه جديد شو اسمه الموقع اللي بتعملوا عليه سبمشن الالكتيف؟
فيسبا.
فيسلا.
بس
كانت فيسلا بي اس ال. سو اللي صار انه فاندربلت كانت هي اول سنه بتفتح فيسلا، وكان يعني مش عارفين البروسيس، فاي ابلايد فور 2 months وذي جيف ات تو مي، واغلب الدفعات هيك عملوا، بعدين غيروا القرار. فهي اللي صار، يعني على وقتي انا اي ابلايد برودلي وما لقيت الكتيف. هي شغله يعني صعبه وانفورtunate but what I recommend is start early, start like even like early in the fifth year to look for places, لانه اغلب الplaces they will be filled up quickly. For example عندنا احنا بكيو يعني it gets filled up for 48 months ahead. فيعني اذا حد مثلا بده elective KU it should be like the beginning of fifth year or ممكن نهايه الفورث year. مش كل الاماكن زي هيك، بس يعني مثلا كيو. ف my first advice انه start looking for places very early. الشغله الثانيه اذا واحد صحت له elective مع الجامعه، هي يعني ايش مكانتها؟ اتوقع الجامعه لساتهم ببعثوا فاندربلت، ببعثوا له UIC، لساتهم ببعثوا له اوهايو هيلث ولا بطلوا؟ اوهايو.
يعني اللي هي بس
لا ما
يو اي
ببعثوا.
سي.
بس UIC
وسان جود كمان.
سين جود يا. فاذا حد بيطلع له مع الجامعه ياخذها، حتى لو مثلا هو بده مثلا اذا حد طلعوا له سين جود ياخذها سين جود، اتس فاين حتى لو بده نيورو. لانه شوي صعبه الواحد انه يجيب الكتيف، والالكتيف مع الجامعه مضمون يعني خلص، هي بكل واحد ضمن شهر. الطرق الثانيه انه هو ممكن يعني ممكن واحد يطلع له شهر بالجامعه ويتواصل معهم انه يعملوا اكستنشن لشهر ثاني، ممكن تزبط مرات. يعني احنا على اساس سنتنا كل الفاندربلت طلعوا شهرين، يعني انه الجامعه اعطتنا شهر، بعدين احنا وي دبل ابلايد وكلهم اعطونا شهرين. الثيرد ابروتش اللي هو في some places مايو كلينيك كليفلاند اتوقع بويل كورنيل the big names they have like a centralized application system but الواحد لازم يكون عنده step 1 اتوقع TOEFL. If you are done with step 1 you can submit your application and see. The chances are fair، يعني إذا واحد والله بخلص step 1 وعنده TOEFL يعني it's like a 20-30% chance. مايو كلينيك وكليفلاند المنيح فيهم انه غالبا ما في tuition fees, it's only the application fees, but it's to some extent it's more of like gambling لانه you are paying application fees ahead. If you get the spot it's you get the spot in Mayo Clinic for like $200-300, which is super cheap compared to other places. But there is like a relatively high rejection rate, so this is the second way to get it. Third way اللي هي البي اس ال او just apply broadly. There are like some like for example ما بعرف كيو احنا هون عندنا اذا كان على البي اس ال او ولا على الويب سايت، بس KU one of the places that's elective is super standardized like similar to my clinic in Cleveland, so KU it's very similar to them. KU ما بيطلبوا step 1. The process is very straightforward. You have an application, ترفع السي في والapplication material we wait for a response. مرة ثانية KU بيقبلوا يعني نسبة الاكسبتنس ريت منيحة but you have to apply very early on. وما بضمنوا سبيشاليتي عندنا هون KU، يعني you apply for neurology you might get like cardiothoracic surgery or something. So yeah this is the third way to do it. The last way إنه هو if you have a connection. connections مين ممكن يكون connections هنا؟ يكون في attending in an big academic institution، يكون هو attending الرول تاعه، هاي كثير هاي بلس ممكن يعني يساعدكم. الشغله الثانيه residents ممكن يساعدوا بحاله واحده انه اذا البروجرام ما كان في structured elective program، يعني مثلا والله عندهم بالجامعه ما في شيء اسمه elective و standardized application، لا خلص يعني مش كثير شغل standardized، والله بحكي مع البروجرام دايركتور، بحكي مع الجي ام اي و they will get the spot. ف if you know if you know a resident or someone who can help you can talk with them. وصراحه يعني don't feel ashamed انه you are texting residents. يعني انا مثلا ما اقدر كثير اساعد بالالكتيف، بس بيصلني يعني questions من students so I'm totally fine I'll be clear with them like I'll try to help. بس شغله مش مضمونه، بس try to contact residents. اذا حكوا لا it's fine لانه بالاخر الشغله مش بايدهم، بس في some programs they will help you. اخر طريقه if you know a physician in the United States حتى لو ما كان academic institution اذا كان بكوميونتي هوسبيتال او برايفت كلينيك كثير سهل يجيبكم. اذا كانت كوميونتي هوسبيتال بيقدر يجيبكم عنده. المشكله الوحيده انه it's not a university hospital. البرايفت او الكوميونتي هوسبيتالز it's easy to get an elective in لانه ما يعني it's not a teaching hospital. بس انه انا بحكي مع اداره المستشفى انه انا بدي اخذ الستودنت الثاني واتس فاين. اتس يعني كيف انه هي it's a compromise بس it's better than nothing. بضل انه having exposure there is better than nothing. وبالاخر يعني anything is better than nothing. يعني اذا واحد طلع له 1 month بعد الجامعه وما طلع له شيء ثاني it's fine. 1 month is fine. وبعرف ناس they matched without any elective experience. يعني عندنا واحد من اول بروجرام من الاردن نيورو معنا ما عمل elective من مره وهي matched. فالelective is not a must, but it will increase your chances. Like without an elective, your chance to match is like 40-50%. With an elective, it's like 90-95%. 1 month is I'd say 1 month is enough. إذا واحد ما طلع له شهر ثاني 1 month is also enough.
شكرا دكتور.
Is it not
وانا أمنت
سوري قطعتك. لا احكي يوسف.
انا امنت شهر بس انه كنت بدي احاول الاقي كمان شهر، فعشان هيك بلشت اتواصل مع اكثر من دكتور. ان شاء الله يعني نحاول نلاقي شهر ثاني. بس زي ما انت قلت راح احاول برضه اقدم على انترنال ميديسين، اذا طلع لي برضه مش غلط يعني.
بحكي بالالكتيف لا تكون كثير بيكي. يعني حتى لو ما طلع لك ولا شهر نيورو just go there and get the exposure.
فهمت عليك. شكرا.
هون بس بقدر احكي كمان انه I have people applying who بدهم كارديو مثلا. عادي يعني زي ما حكى محمد don't be picky. يعني هم هلا طالعين infectious disease و interventional radio مثلا. اوكي او مش مثلا يعني it is a person يعني، بس هو بالاخر بده يقدم كارديو. المهم بس انه it's a US clinical experience يعني that's important. ثاني شغله كنت اسالك محمد، طب انت عم تعطينا هلا هدول الاشياء، بس انا بصراحه I see the outlook is kind of يعني more bleak currently with the current match cycle واللي بعده. الماتش سايكل هلا 2024 يعني vicious كثير، ولا does that not apply to neurology يعني كثير.
شو السؤال مرة ثانية؟
يعني انت عم تحكي عن اشياء كثير منيحه كثير، يعني انا تفائلت كثير، بس when you take a look مثلا على محلات ثانيه مثلا يعني بديش احكي ردت يعني it's not really representative كثير في selection bias يعني، بس انه بشكل عام يعني الماتش سايكل is very vicious. I don't think انه حتى يعني anything less than 2 months of electives works really. ولا انت شو رايك؟
هسه هي الفكره. يعني الفكره انه الافضل واحد يكون عنده 2 months of elective. هي the way that I'm shaping it. يعني الستاندرد هو كان انه having 2 months of elective. بس اذا الواحد ما قدر يحصل 2 months 1 month is not bad. يعني if you work on other things يعني for example with 2 months of elective your chance is like 90%, 99.5% to match. With 1 month of elective your chances are like 70 or 80% to match. Without any elective it's 40%, but it's still there. Like if you work in other aspects you can still match. فهي الشغله انه الماتش مش تشيك ليست انه 2 months of elective specific score in USMLE 5 researches. It's not a checklist. It's the holistic application. elective is part of it بس هي مش كل شيء. الشغله الثانيه المهمه ليش الناس ما بيروحوا elective ما بيطلع لهم ماتش. مش بس يعني هي مش بس قصه الماتش، مش قصه المانثs of elective، لان بالاخر انت you apply to ERAS elective is like a small section in the CV and ما في verification. You can write whatever you want. ويعني في كثير ناس اصلا ما بيطلعوا عليها. بس اللي بيختلف ايش اللي هو الكونكشنز letters of recommendations. لما يكون عندك US letter of recommendation تختلف. الشغله الثالثه your perspective will change. لما تكون انت ما عمرك عملت elective in the United States, you never practice there, your mindset and the way that you are kind of tackling your interviews or writing your personal statement would be very different. يعني they can tell انه يعني انت يعني حتى انا لما كنت اقابل يعني اطلع على البرفورمانس تاعي بمقابلات ريزيدنسي وهسه بالفيلوشيب some of my answers were like very premature honestly. لانه ما عندي perspective انه what is neurology, what is actual clinical practice in the United States. فاتوقع هاي الشغله بتختلف انه your interview performance will change a lot if you've been exposed to the United States system and having strong letter of recommendations and connections as well.
أنا حابة أسأل كمان يعني إيش البنفيت تبع إنه الواحد يعمل باللارج university hospitals مثلا post doctoral research عشان إنه يمتش عندهم، ولا إنه مثلا يقدم خلص يعني أشياء مختلفة بالسكور تبعه بالإلكتيف تبعه وخلص. فإيش بتحس مثلا أحسن يعني من ناحية الريزيدنسي ومن ناحية كل إشي؟
اوكي
يعني أنا بفكر هدول الخيارين لساتني مترددة إنه أعمل الامتياز بالأردن وأشتغل أكتر مثلا على الستيب 2 سكور ولسه ما قدمته، ولا أجي post doctoral research مثلا هون سنتين معظمهم، ما في سنة، أو يكون paid لمدة سنتين وبقدم مثلا step 2 بعد شهرين من لما أوصل هون، وراح يروح علي حفلة التخرج كمان. هاي المشكلة.
ما راح
فمش
يروح لك شيء.
بتوقع كلهم بيبدوا بأول 7 بتروح علينا الحفلة. بس
اوكي
مشكلة، بس بمزح هاي يعني مزح. شو رأيك؟
هسه بالنسبة لي البوست دكتور ريسيرش فيلو it's not a must for neurology for other specialties. يعني والله يعني الواحد بده يدخل surgical specialty or radiology it's a must. لانه احنا يعني ما عندنا chance تقريبا as IMGs to match there. هي يعني بتطلعوا على الكومبتitiveness، يعني dermatology, neurosurgery, ENT, these things are super competitive. هون الواحد بيحتاج 1 or 2 years of research fellowship. The other situation ممكن واحد يعمل فيه research fellowship انه they were forced to come to the United States لسبب معين، ظروف عائليه، اجوا United States و they are not ready to apply to the match. Doing a research fellowship it's fine. For neurology ما اتوقع لي يد كثير منها. يعني اذا واحد عنده decent CV just go and apply to the match لان it's wasting more time. وما راح تفرق كثير يعني بالاخر you will يعني most of the neurology programs are good. Most of them are university hospitals. It's different from internal medicine. Internal medicine في كثير programs community وهيك. بالنيورو يعني بنعدوا اصابع الايد community programs. So most of the neurology programs are good. الاغلب راح يجي مقابلات if you have a good CV يعني good scores, good letter of recommendations, you will get interviews from good places. انا بالماتش اجاني مقابله فاندربيلت وانا ما بس عملت انهم 1 month of elective. It's mainly because I had like a good CV, I had good scores and some publications وعملت elective عندهم. فيعني ما اتوقع it could worth it to waste 2 years just to get an interview from Vanderbilt. وبالاخر الكواليتي اوف تريننج از نوت بيج ديفرنس. يعني مثلا شو البيجست نيورولوجي ريزيدنسي بروجرامز الواحد ممكن يفكر فيهم؟ مثلا سنسناتي او سنسناتي، هارفارد، هذول مايو كلينيك، هذول البيج نيمز. اذا بقارن التريننج تاعهم بتريننج تبع وين مثلا اوكلاهوما او اركانسا which is still university hospitals ما في ديفرنس كثير. ما في يعني مش هالبيج ديفرنس بالتريننج. واتس نوت بيج ديفرنس ان ذا نيم. ولو واحد مثلا بده يدور على شهاده من مكان يعني من اسم كبير انه انا جراجويت من هنا it's very easy to match in a good place بالفيلوشيب. الفيلوشيب not competitive. اغلب الناس بيعملوا ريزيدنسي بمكان يعني اي مكان عادي، مثلا اي مكان افريج بس تكون university hospital you give the same quality of training compared to the big names. ممكن فروقات بسيطه بس as exposure كنيورولوجي ريزيدنسي ما اتوقع فيه difference. الديفرنسز ممكن تكون بالكول سكادجول البروجرام مالجنت ولا لا but it's not a big deal. وبعدين بالفيلوشيب you can easily match in one of your like big names كثير يعني. ف would it worth it؟ ما اتوقع ان واحد to waste 2 years just to match a specific program if you still have a chance to match in other programs, and probably you will have a chance to match even in Vanderbilt and like big names neurology if you have a good CV. هاي شغله.
فهمت عليك. يعني أنت شايف إنه خلص يعني إنه الواحد ما يضيع هالسنتين يعمل الامتياز بالأردن
بالضبط يعني حتى let's say ما طلع لك فاندربلت وليتس سي
لا مش أنا مش إنه حاط فاندربلت هي يعني اللي بدي إياه مثلا، بس إنه يعني هذا في يعني مجموعة ناس قالوا لي إنه هيك بتكون الشانسز تبعتك أحسن إنه تمشي ببرامج أحسن إذا أنت عملت البوست
definitely ممكن شوي ترفع تشانسز. راح ترفع تشانسز بالريسيرش هيفي بروجرامز بس الشغله الثانيه if you have a decent CV you will get interviews from these places. يعني it's not a big deal. وبالاخر يعني even if you يعني اذا ما متشتي بمكان كثير توب بالريزدنسي تقدر تمشي هناك بالفيلوشيب ايزلي.
فهمت عليك. شكرا والله.
sure. All right. So let's go to the other section. We'll go over it very quickly, just an overview for subspecialties. وبالاخر راح نفتح كمان باب الاسئله بشكل زياده. So حكينا عن what is neurology, how neurology is different from neurosurgery, psychiatry, internal medicine, what's the day-to-day life as a neurologist. حكينا عن match process, but what's next؟ يعني what are the fields that you can subspecialize in. شغله مهمه، الفيلوشيبس والسبسبيشاليتيز بالنيورولوجي are different from internal medicine. كيف؟ الانترنال ميديسن دكتورز they are like general hospitalists or GPs. يعني internal medicine باليونايتد ستيتس هو equivalent GP بالاردن. فبالتالي as an internal medicine doctor باليونايتد ستيتس you can't practice like cardiology as a cardiologist. You can't practice nephrology. That's why fellowships are a must بالinternal medicine. It will change your practice. يعني GI physician is different from internal medicine physician. Lifestyle different, the scope of care difference, different, السالري كثير بيختلف. بالneurology, most of the neurologists will practice general neurology. يعني let's say someone is a neuroimmunologist, 80% to 90% of their clinic will be general neurology. Unless you are working in a big academic center, you are only taking care of neuroimmunology patients. Same with stroke, same with everything. And most of the places you can work both. يعني والله إذا أنت كنت متخصص stroke, you can work as a neurohospitalist, but you can also work in the clinic. You can negotiate for both contracts. فالفيلوشيب مش كثير بتعمل restriction بالنيورولوجي، وما في added value بالفيلوشيب. الفيلوشيب is an extra layer of training. You will be an expert in the field. But as a general neurologist, you can do all the procedures and treat all the diseases by all different specialties. يعني as general neurologist, you can treat MS, you can do EMGs, you can read EEGs. But for example, most of the general neurologists, they don't feel comfortable reading EEGs for sick patients. You need an epileptologist or neurophysiologist. Same with Botox. Like, yeah, all neurologists will do Botox, بس والله مريض عنده dystonia or complex that movement disorder specialists will do it. The only exception is in interventional neurology. You need training. You can't practice interventional neurology without subspecialty. Okay. هسه راح احكي عن كل subspecialty, what is the scope of this subspecialty and how different it is from general neurology. So the first, my favorite subspecialty in neurology is vascular neurology. So vascular neurology is different from interventional neurology. Vascular neurology is a branch of neurology side on interventions and give thrombolytic is the vascular neurologist. Ideally, it's a vascular neurologist. In a lot of places, general neurologists can do that. But in big centers, vascular neurologists will do it as well. Vascular neurologists also manage brain bleeds. So brain bleed is a surgical disease. Bleeds are surgical. Neurosurgeons will manage the acute phase. But usually the question after that, like, why the bleed happened? Then, so once the patient is stabilized, the patient will be sent to inpatient neurology, or the vascular neurology will be involved to answer the question. So, like, this is the nice thing about vascular neurology. Yeah, you do acute care neurology. It's the most acute part of neurology. You do stroke management, you do brain bleed management. A lot of acute stroke responses are not strokes. So you'll be managing other acute neurological stuff. Like, they will call you in a patient with right side weakness. You examine the patient, and this is post-ictal. The patient is in focal status. You start treating their seizure. Is purely vascular neurology, but
يس سامعينك بس
بس الريكوردينج وقف. اوكي في الشغل كنت احكي عليها انه it's called cerebrovascular accident. It's not an accident, it's an ischemic stroke. It happened for a reason and we have to find it out. هاي بيلخص الرول of vascular neurologist. بعيدا عن الاكيوت phase, بعد ال stabilization of brain bleeds with strokes, we answer the question why this happened and why how can we prevent it. فبنعمل stroke workup of cryptogenic stroke or ESAS, embolic stroke of indeterminate source, workup for brain bleeds. Some brain bleeds, like, they are not straightforward. Like, some patients would have like cerebral amyloid angiopathy. Some of them have like like underlying brain tumors. So we do this workup, and we will work really closely with neurointensivists and neurosurgeons as vascular neurologists. So this is vascular neurology. As an outpatient, there's a role of vascular neurologists. Some of them will do outpatients, but it's like a heavily inpatient specialty. Most of the neuro hospitalists are stroke trained, are vascular neurologists as well, because it's half the hospital patients. And their stroke neurologists are really good in like the acute management of neurological complications. Because like we see other stuff, like other emergencies. We see seizures, we see neuromuscular emergencies, we see like toxic metabolic encephalopathies, like acute hepatic encephalopathy or uremic encephalopathy. The initiation of the treatment, the diagnosis is done by the vascular neurologist most of the time. Another thing, like an added skill that you can do as a vascular neurologist, is doing a transcranial Dopplers and carotid Dopplers. This is purely done by vascular neurologists. General neurologists can't do that. And you can do telestroke. So in some places, there will be only one comprehensive stroke center in the whole state. So we'll be doing telestroke, kind of managing your patients through video conference. And you can't do that unless you are stroke trained, because there are some skills. You need to examine your patients through Zoom or so. Okay. The second specialty is epilepsy. Epileptologist is the typical neurologist. So like if you look at the stereotypical neurologist, this is an epileptologist. Epileptologist is the person who reads EEGs. Epileptologist is a person who manages the electricity of the brain rather than the vascular part of the brain. Like when I think about it, stroke neurologists are still neurologists, but they're very close to cardiology rather than neurology. They think more about hemodynamics. But thinking about the actual function of the certain brain areas, electrical activity of the brain, how can we modulate certain receptors, this is epilepsy. Epileptologists, usually they spend their time half and half, like 50-50. They usually have a clinic, but they cover inpatients. They are the experts in reading EEG. So all neurologists are kind of certified to read EEGs, but not all neurologists are comfortable with that, because some EEGs would be, especially the ICU EEGs, would be very critical and like life-saving. So usually an epileptologist will be reading these. Epileptologists will be also managing an epilepsy monitoring unit, where we admit epilepsy patients to either classify their seizures, to see if these are even seizures or like something else, or a seizure mimic. And we also admit patients for localization of their seizures and starting surgical workup. So epileptologists work really closely with surgeons, neurosurgeons, and epilepsy workup, and also they help in intraoperative monitoring, not only for epilepsy surgery, but for brain surgery itself. And it happens sometimes that patient gets a stroke during the brain surgery. So the epileptologist will be the first one to recognize that and like intraoperative monitoring. So there's epilepsy, and it's like a huge, interesting field of neurology as well. And epileptologist is an expert in medical treatment for epilepsy. It's not straightforward. Like, so all neurologists will treat epilepsy, but treatment refractory epilepsy, they should usually see an epileptologist. Like beyond the second medicine, then you need an epileptologist, because it gets really tricky, kind of adjusting different mechanisms of actions and drug interactions, and choosing the right treatment for every single patient. And I'd say pediatric neurologists deal with the most interesting epilepsy patients. Like as an adult neurology, we see seizures, but pediatric neurology, pediatric epileptologists, they do like amazing job. Then we have movement disorder. So movement disorder is like 80% Parkinson's disease, 10% tremors, and the rest are other movement disorders. Common diseases that are treated by movement disorder specialists are definitely Parkinson and Parkinson plus syndrome. So atypical Parkinsonism usually are treated by specialists. Like general neurologists can diagnose and treat Parkinson, that's totally fine. But if you diagnose something very rare, then you should refer them to movement disorder specialists. They treat also genetic movement disorders, like Huntington's disease is the most common one. They also treat tremors. They are like one of the most common things that they see. Dystonia. Movement disorder specialists do a lot of procedures, so Botox injection. So all neurologists will do Botox for migraine. So nowadays it's a standard of care for neurologists. Like all neurologists will be trained, are certified to do Botox for migraine. But beyond that, it gets tricky. And if you're doing Botox for spasticity and dystonia, then you need a movement disorder specialist. Some of the stroke specialists can do Botox for spasticity as well, but usually it's the movement disorder specialist. Movement disorder specialists also work do the surgical workup for DBS placement. They kind of screen the patients, do the workup, guide the surgery as well. So they usually be in the OR with the functional neurosurgeon to implant the deep brain stimulation for Parkinson. And they do it also for tremors, for dystonia, so it's not only Parkinson. And movement disorder specialists, they usually program the DBS. DBS programming is really hard, and specialists will do it. Usually it's like multiple sessions that needs longitudinal follow-up with the patients. So for example, most of movement disorder things are done by general neurologists, but like there are some skills that you need to learn if you're a movement disorder specialist, like Botox, like DBS programming, and management of complex atypical Parkinsonism, like progressive supranuclear palsy or corticobasal degeneration. These patients are very sick. It's hard to treat them as general neurologists, and they need like a collaborative care. The fourth one, which is the specialty that's very close to internal medicine, which is neurocritical care or neurointensivists. So neurointensivists are people who treat with the sickest patients of neurology, and they are usually really good in internal medicine. Like if someone did neurology residency and they really like internal medicine, neurocritical care is for them. They do a lot of internal medicine in terms like of blood pressure management, airway management. They are experts in intracranial pressure management as well. So ICP monitoring and management is done purely by neurocritical care. They take care of all life-threatening emergencies in neurology. So like stroke patients, hemorrhagic or ischemic, neuromuscular crises if they require intubation, spinal cord injuries, neurosurgery patients post-operatively. They also take care of like patients with lumbar drain. So if a patient has a really bad meningitis and they need lumbar drain management, usually they will be in the neuro ICU. The nice part about neuro ICU is that their job is very close to surgeons. So if someone is very hands-on and they like to do procedures, neurointensivists are like probably the most specialty that do procedures, and they're very close to surgeons. So talking about procedures in neurology, a general neurologist is able to do LPs. All general neurologists will be kind of board certified in LPs. Usually by the end of second year, you'll be board certified. You'll do like at least 5 to 10. They can theoretically do EMGs, nerve conduction studies, EEG theoretically, but most of them, they don't feel comfortable unless they have a subspecialty on it. And all neurologists will get board certified in Botox for migraine as well. So these are the general procedures that we do, any neurologist. A neurointensivist will be able to manage even more things. So they are the experts in LPs. They're even better than general neurologists. They can do intubation, central lines, arterial lines. Some of the neurointensivists can do lumbar drains and external ventricular drains as well, EVDs. Although most of the time EVDs are done by neurosurgeons, not neurologists, not neurointensivists, but some neurointensivists will do EVDs. So if someone is like really likes internal medicine and neurosurgery, but wants still to be a neurologist, neurocritical care is the specialty for them, because you're technically an internal medicine specialist when you are a neurocritical care physician. The next subspecialty is neuromuscular medicine and / neurophysiology. So when we think about neurology, we think mainly about the brain, but keep in your mind that almost half of the nervous system is the peripheral nervous system. And if you don't like the peripheral nervous system, then you don't like half of the neurology. So yeah, it's the most tricky part of neurology. The most part that like the anatomy is really difficult for the peripheral nervous system, but it's important. A neuromuscular specialist is the expert in doing EMGs and nerve conduction studies. Again, all general neurologists theoretically can do it, but apart from like diagnosing carpal tunnel syndrome or like mild neuropathy or myopathy, apart from these simple things, usually a neuromuscular specialist is needed to diagnose like myasthenia or myotonia or things that are more advanced. They usually manage all the nerve and muscle diseases. So they are experts in management of myasthenia gravis, management of myopathies, myositis. So myositis, by the way, and myopathies are managed by us. They are not managed by rheumatology. Rheumatology can help with the adjustment of treatment, but we are the primary on these patients. So myopathies, myotonia, dystrophic muscle diseases, Guillain-Barré syndrome. Most of the neuromuscular physician job is as an outpatient. They work in the clinic. They rarely come to the hospital. Yeah, so this is neuromuscular. Neurophysiology is like a hybrid specialty. So they get the training of neuromuscular and epilepsy. A neurophysiologist is someone who's trained in reading EEGs, EMGs, and nerve conduction studies. They are the experts in doing these procedures. Most of the neurophysiologists will have like some background in neuromuscular medicine as well. That's why like a neurophysiologist is like 70% neuromuscular specialist and 30% epileptologist. Neurophysiology is a very interesting and specialty if you are interested in outpatient neurology. If someone wants to practice general neurology as an outpatient, having a neurophysiology fellowship is very helpful. So you can kind of do your own EEGs and EMGs, and like basically you can be an independent neurologist if you are board certified in neurophysiology and open a clinic. Most of the other specialties you need to be in a big center. And I'd say most of our attendings بالاردن يعني عاملين نيوروفيزيولوجي، لانه بالاردن اذا واحد بده يشتغل لحاله يفتح عياده يفضل يكون مع نيوروفيزيولوجي. Next, neuroimmunology. Neuroimmunology is the most growing and interesting field in neurology. We treat demyelinating central nervous system disorders as well as brain inflammation, autoimmune encephalitis. Neuroimmunology is very close to rheumatology and oncology. I'd say most of the general neurologists will feel comfortable kind of diagnosing and initiating the treatment for neuroimmunology. But the problem with these patients is that most of their medicines are very expensive, and most of these medicines are dangerous. Like technically, you're giving them chemotherapy for the MS and autoimmune encephalitis. So neuroimmunology specialists are more comfortable with that. Like I look at them as the oncologists of neurology. So oncologists, they are the experts on these dangerous medicines. Neuroimmunologists are experts on these medicines, how to get the insurance to approve them, how to do dosing for them, how to counsel the patients, do follow-up. So this is purely the role of neuroimmunologists. Most of the neuroimmunologists also have good training in neuroinfectious disease. So there is no actual neuroinfectious specialty. Most of our ID patients are seen by infectious disease specialists, but a neuroimmunologist is technically an expert in brain infections as well. Then dementia or neurocognitive, or some people would call it also neuropsychology. It's so if someone really likes neuroanatomy, this is a specialty for you, because like the only specialty that you look at every single brain circuit and how it functions and how any damage would cause the symptoms is dementia or neurocognitive. They are really good in neuroanatomy. The role of dementia specialist is kind of minimal, compared to general neurologists, because general neurologists can diagnose and treat dementia. A neurocognitive specialist is different from general neurologists in three different aspects. So first, most of the dementia specialists are certified in neuropsychology, so they can run the whole neuropsychology psych panel and kind of localize the lesion and kind of detect patterns of dementia and brain dysfunction. The second thing about dementia specialists is that they can give you the exact diagnosis of your dementia, and they can give the patient like more access about the prognosis, support groups, what to expect, because like most of the general neurologists, they won't do the full dementia workup, but and a neurocognitive specialist, they would do like a full neuropsych evaluation. They will do like a functional brain MRI and PET scan and give you the exact diagnosis. Is it frontotemporal dementia, Lewy body dementia, or something like that? What would you expect? How can the family handle that? So they're really good in counseling and education for their patients. The third thing is research. So most of the dementia specialists are heavy in research. I'd say like we have a KU, we have Alzheimer's Center, like it's a different like separated buildings, different hospital. Most of the dementia specialists are heavily involved in research. Like they are kind of diagnosed. So what they do is they see the patient for the first time, they diagnose them, solve the puzzle, and then if the patient is eligible for a clinical trial, because there are a lot of promising Alzheimer's treatments, monoclonal antibodies, then they will enroll the patient in the clinical trial. If the patient if the patient is not eligible for the clinical trial, and they solve the mystery to diagnose the patient, then usually this patient will be sent to the general neurology clinic to follow up, usually to the resident clinic. So this is the role of dementia specialist, and usually they work in a like big centers, because like you don't need a dementia specialist in a community hospital. Like a general neurologist can handle that. And last but not least, probably most of you are thinking about this. It's the most interesting part and most growing part of neurology, which is neurointerventional. So neurointerventional neurology is the specialty where you basically treat the cerebrovascular dysfunctions. You treat large vessel strokes by thrombectomy. You do coiling for aneurysms. You treat AV malformations. Some of the interventional neurologists will also treat like venous stenosis, which is controversial, but some of them will treat it. They can also do treat spontaneous intracranial hypotension, do like myelograms, angiograms. So it's more of a radiology, so a realm of neurology, more of imaging and diagnostics. Now, it's still controversial whether it's a part of neurology or it's technically part of radiology. Yeah. So most of the places would prefer neuro ICU to be like someone to be neurointensivist before applying for interventional neurology, because they do a lot of procedures. But there is a big overlap. Like vascular neurology, neuro ICU, and interventional neurology, they are like technically the same specialty from like different perspective. Most of the places, if you are an interventional neurologist, you will be functioning as a radiologist. That's it. So you'll be doing the procedures, but not doing any clinical work, because the caseloads are very heavy. Some places, peripheral places, you might be asked to be like the on-call vascular neurologist, which is like the ideal situation. Like if someone wants to be a interventional neurologist, you want to diagnose your patient, take them to the IR. But unfortunately, this is not the situation. Like you don't see the patients in the hospital. You don't make the decision. You just do the procedure. What's nice about it? So it is most rewarding part of neurology. It's the most competitive specialty, though. You're technically applying for neurosurgery, which means that like you have to finish neurology residency, you have to finish another fellowship, you have to have like an impressive CV to compete with neurosurgeons for this spot. So these are the good parts about it. المشاكل اللي فيها أولا اللايفستايل. You are technically a neurosurgeon, so you're on call all the time. You do a bunch of procedures. Usually it's only one neurointerventionist covering the whole hospital. الشغلة الثانية, you are kind of shining away from neurology. You are not doing a lot of neuro exams. You are not kind of solving the diagnostic puzzle, but you are more now just treating the acute thing, doing the procedures. So you are more like a surgeon now. So yeah, if you are like a procedure person, neurointervention is for you. But the thing is, the like salary wise and payment راتبهم يعني أعلى شيء. Neurointerventionist, they are like their salary is similar to neurosurgeons or interventional cardiologists. It's like maybe 5 or 6 times the salary of a general neurologist. Okay, so by that we finished the overview of neurology and subspecialties. To summarize, neurology is for you if you are someone who really likes neuroscience and neuroanatomy, someone who really likes dealing with patients, doing comprehensive physical exam, and someone who likes solving puzzles and kind of use deductive reasoning to reach the diagnosis. We are done with the presentation now, but I'm happy to take any questions about match, specialty, anything else.
بتقدر تحكي لنا شوي عن النيورو ophthalmology؟
Yeah. So التخصصات اللي حكيت عنهم هم الموست commonly taken specialties. بس في other subspecialties. واحدة منهم neuro ophthalmology. غالبا the ophthalmologist will do 1 year of neuro ophthalmology, but neurologist can still do neuro ophthalmology. A neuro-ophthalmologist is the specialist in testing visual fields, treating and like optic nerve, So any like optic neuritis treatment, optic neuritis diagnosis, papilledema, intracranial hypertension management, cortical blindness, visual pathway lesions, cranial eye movement disorders, like problems with the like third cranial palsy or so. Usually they are seen by neuro-ophthalmologist. However, most of the neuro-ophthalmology patients will end up being seen by neurology before general neurology. A neuroimmunologist will see most of the optic neuritis patients. Neuro-ophthalmologist lifestyle is amazing. It's mainly outpatient, clinic hours. Your patients are not very sick, but you don't do a lot of procedures. If you are not an ophthalmology trained, you can't do any procedures on the eye. You can do the neurology part of neuro-ophthalmology, but not more procedures. If you are ophthalmology trained, then yeah, you can practice neuro-ophthalmology, but you can also do minor procedures on the eye as well. Other common subspecialties are not common, but like you can do them. So neuro-oncology, you will be diagnosing and medically treating brain tumors and kind of planning this the options with the surgeon. Neuro-otology, although most of neuro-otologists are ENT trained, so issues with the inner ear and vestibulocochlear nerve. Then we have neuro-rehab, which is usually taken by rehab medicine doctors, but you can do it as neurologist. And then sleep medicine. Sleep medicine is part of neurology, psychiatry, and internal medicine. So if you are neurology trained, you can do sleep medicine as well. Neurology trained sleep medicine doctors usually focus more on narcolepsy management and like hypersomnia and these stuff, compared to medicine trained who treat obstructive sleep apnea more.
أنا هون عندي سؤال لو سمحت. هلا generally speaking خلينا نحكي لإلهم عشان هو it's a big topic generally in any type of residency application that you want to do. شو ال average number of publications that a student needs to apply to the match cycle successfully للنورولوجي؟
بس الشغله ما هي الفكره، ما في like magic number, like if you cut this point that's it, you'll do it. I know people who had no publications and they matched. I'd say most of the residency applicants ما عندهم publications, they will match. But to be a competitive applicant, I'd say like 3 to 5 is a good number just to be a competitive applicant. وهي الترند، يعني انا لما اشوف الاي ام جيز specifically لما اطلع السي في تاعتهم usually they have like at least 3 to 5 publications to get like a good amount of interviews.
يا محمد لازم هدول ال publications يكونوا بالنيورولوجي، يعني I have publications and يعني عندي submissions بس ولا واحدة بالنيورولوجي.
It's totally
لأنه
fine.
بتعرف إنه شو اسمه إنه مش كتير في فرص بتلاقي بكل مكان، فإنه يعني لازم مثلا هلا أعمل جهد أكتر إنه أعمل نيورولوجي ولا خلص إنه اللي موجود وخلص.
الأفضل يكون في neurology، بس يعني أنا when I applied to the match I had no neurology publication at all. I had 10 publications but none of them were.
I have like a neurosurgery. Is that
which is close to
yeah.
فهي يعني هم الفكرة they want to know that you like you are dedicated, you know how to work as a team member, you know how to complete a project, and you know the publication process. بالآخر it's not a research fellowship, it's a clinical fellowship. But having research background is good. كمان احنا IMGs فيعني to be competitive you need kind of relatively more research compared to US graduates. So I'd say having 3 to 5 is a good number. زمان كان if you have only one application it's totally fine, like 5 years ago. بس هسه لأنه step 1 صارت pass fail، وبشكل عام الترند they are doing more publication. يعني حتى ال US graduates 5 years ago ما حد كان ينشر. هسه attending لأن بالريزدنسي ما كانوا بالميديكال سكول ما كانوا ينشروا شيء. هسه بتطلع medical like medical students in the United States they have like 5 publications or so. فالترند إنه الأغلب عنده publications.
دكتور بدي أسألك سؤال. هلا هلا مثلا أنا السي في تاعي إذا حدا بيطلع عليه رح يشوف إنه الفوكس كله نيورولوجي أو نيوروسيرجري، يعني ما عنديش إشي تاني بأشياء تانية. هل إذا لازم مثلا هلا أنا بدي أقدم نيورولوجي وفكست عليها، إذا بدي أحط باك اب بلان إنه أقدم على انترنال ميديسن، هل خبرتي بالنيورولوجي بتكفي إنهم يقبلوني، ولا لازم أدور على مثلا على إشي بكارديولوجي شوي أو على إشي GI أو إشي زي هيك؟
what I'd say is it's الماتش تاع الانترا ميسن is really easy. It's really easy to match الانترا ميسن. المشكلة بالانترا ميسن إنه if you are not interested in internal medicine you will match في الآخر if you apply everywhere but you will match in a community hospital مش كتير منيحة. هاي مشكلة internal medicine. If you are looking for a good place in internal medicine you should have some experience in internal medicine I'd say. Neurology is the opposite. Neurology أغلب places منها. يعني ما عمري لقيت residency program بالنيورولوجي احكي هي community ومش منيح كلهم منها. ف I'd say focus more on neurology and like if you're applying for medicine as a backup plan it's fine and like if they ask you tell them yeah I was interested in neurology and I changed my mind بس يفضل personal statement تكون يعني addressing that at this point يعني it's better to write two personal statements one for neurology and one for internal medicine يعني الفكرة إنه neurology people are fixated you have to have interest in neurology الميديسن people بالعكس لأن أغلب اللي بروح الميديسن هم الناس اللي بيحبوا كل شيء medicine is very broad so I think it's fine يعني ما عندك كثير publications or interest in medicine it's fine if you have like quality improvement public health mental health الشغلات هاي الشغلات technically internal medicine كمان community medicine هذول internal medicine that would be fine
تمام شكرا دكتور.
sure.
محمد كمان يعني أنا عارفة إنه سألت كتير بس حاب أسأل إنه البيرسون ستيتمنت تبعتنا إيش بتحس إنه لازم إحنا نحط فيها يعني كتير مثلا هلا الدكاترة داومت معهم مثلا they ask me for personal statement إنه to send my personal statement عشان يكتبوا letters of recommendations وهاي الأشياء فأنا صراحة مش عارفة شو بدي أحط فيها فإذا بتقدر تساعدني بهاي الشي.
هسا personal statement ما في template واحد يعني هي it's personal اسمها personal statement it's talking about you just يعني showing yourself to people بس أتوقع يعني common themes that you have to address is why did you like neurology يعني أو في ناس خصوصا بالresidency applications they would say start like why did they go to medicine from first place why did you like neurology and what you've accomplished right now and what are your goals so هاي الجنرال theme إنه كيف وصلتي لهون ليش neurology is interesting and what are your goals in the future وفي أكثر من طريقة كتابة يعني ما في one standardized way just talk about yourself try to use simple language فيش داعي تكون Shakespearean English try إنه when you are showing your qualities instead of stating them show examples like give a patient example or an impactful experience in your life rather than saying like I'm dedicated I like reasoning or logical thinking rather than stating them بس give short examples 2 or 3 lines about an experience that shows this thing ويعني personal statement writing it's like a skill that you will learn as you are like applying to the match it would take a couple of months to write like a good personal statement for residency I'd say but for the attending سأل for a personal statement for a letter of recommendation like yeah something simple is fine
okay شكرا.
yeah have any more questions
okay أسئلة
يعطيك العافية دكتور. It was very fruitful and insightful. وthank you للتيم اللي اشتغلوا على البروجكت. My question كان على something you touched on it before بأول السيمينار بالintroduction. شغلة emotional burden خلينا نحكي associated مع neurology إنه most of our patients أو a big number of them يعني you can't reach a خلينا نحكي satisfactory conclusion معهم إنه it's just palliative أو إنه symptomatic for life quality in a way وكثير سمعنا إنه it's a depressing أو خلينا نحكي إنه emotional load أو burden فيها it's very high very taxing من هاي الناحية. Can you speak to this and how true this is in your experience or how much it impacts you personally or your يعني الأفكت تاعك in your work or if you can generalize this للneurology بشكل عام مش بس إنه US UK كمان if you have any knowledge على if it's the same thing يعني.
Yeah. So yeah, it's a really good question. وهي الشغلة اللي بتخلي كثير ناس يخافوا من النيورولوجي. هسا it depends on your perspective and what's your definition of a cure or what's your definition of like the role of physician. في شغله يعني you will realize it with time انه regardless of specialty we never cure illnesses. We mainly either treat the symptoms or we kind of prolong the recurrence of the disease. Like you can start like apart from clear cut things like appendicitis or anything else in medicine شو اسمه يعني بالاخر انت مش قاعد you're not curing it. يعني شو مثلا cardiology, most of your cardiology patients will have heart failure. You will manage their heart failure symptoms, but it's never gone. They will reach a point that they will need a heart transplant unless they died from something else. مثلا ايش spine surgery like or neurosurgery. Most of the neurosurgery patients will be disabled, will be really impacted by their brain tumor or trauma or bleed, but you will make their lives better. مثلا general surgery, most of your patients would have a lot of GI stuff even after the surgery. Same with urology, same with everything in medicine. I think الفرق الوحيد بين surgical specialties والneurology والmedicine بشكل عام bread and butter cases. So most of the patients اللي بيجوا مثلا orthopedics they are healthy patients. مع انه orthopedic patients actual care inpatient care it's horrible. like لو تشوف polytrauma patients broken bones amputations cancers hip fractures, they have like horrible results. بس لانه bread and butter cases of orthopedic surgery most of the patients are healthy patients. They are young, healthy, have broken bones, فالواحد بحس satisfaction. Again, it depends on the perspective. The way that I look at neurology is that we are treating people in need. Like if I want to do the general neurology simple stuff, it's so satisfactory. Headache treatment, so like مثلا bread and butter cases in neurology are headache and epilepsy. It's really easy. Like 9% of epilepsy patients are treated with 1 to 2 medicines, they will be fine. Headache treatment is really nice. You do some procedures sometimes like nerve blocks or Botox and that's it. بس my perspective at least انه like اذا الواحد اصلا ما عنده critical illness and anyone can treat it, so what's the challenge in that? What's our role in that, right? بالعكس انا بشوف انه المريض اللي who is in need, المريض who's very sick, if I can treat them and give them and can reverse the process like in stroke patients or MS patients, this is amazing. If I can't treat them, if I can make their lives better, this is even like really satisfactory. فيعني ما اتوقع انه النيورولوجي is emotionally draining للاكستنت اللي احنا نتصورها, لانه يعني اغلب الديزيز عندنا if they are not curable they are manageable. يعني Parkinson's disease is an easy to manage. Parkinson's انا بالنسبه لي مريض باركنسون مش يعني Parkinson is not a debilitating disease. Parkinson could be managed. Epilepsy could be managed. Stroke early on could be managed. Most of MS patients could be managed. يعني بضل بس جزء بسيط من مرضانا mainly مرضى الدمنشيا. يعني apart from I say Alzheimer, maybe Lewy body dementia, other types of dementia are horrible. عندنا مرضى movement disorders apart from Parkinson's disease, مرضى Huntington, progressive supranuclear palsy and atypical Parkinsonism, they have horrible prognosis. And مرضى ALS. يعني anything apart from that, I don't think there's a lot of emotional burden. Like you can technically treat your patients. And most of the neuromuscular diseases, for example, like myasthenia gravis, it's really easy to treat and it's really satisfactory. Guillain-Barré syndrome, myositis, myopathies, the myotonia spectrum disorders, most of them, they are really easy to treat. هي المشكلة بتضل بس باللي I'd say ALS with dementia with some variants of Parkinson. Apart from that, there's not a lot of not a lot of emotional burden. It's mainly like what are your expectations? That's it. If you expect that all your patients will be cured 100%, this is not even a realistic expectation for medicine overall. Like there is no physician who can cure all their patients, or apart from like young patients. Like even in neurology, if you're having a young epilepsy patient or a young headache patient or like spontaneous intracranial hypotension patients, yeah, we can cure them. But the thing is, most of our patients are old and sick, and helping them is, I don't know, it's so satisfactory. And even in neuropediatrics, like in kids, يعني أنا كم مرات كنت أتساءل إنه يعني ليش في تخصص neuropediatrics? You are treating kids with developmental delay, they will die in 2 years, they have CP. But no, most of these kids are like now growing up, reaching their 20s and 30s. They're like functioning, I mean, part of the society. And you are helping them to grow up. Yeah, they still have the disease, but they can walk, they can function. بعضهم بيشتغل. فهي role of neurology is to maximize the function of our patients. yeah, if you tackle neurology from this philosophy, I don't think there's a really burnout or burden. I think the most frustrating thing about neurology is the psychogenic symptoms or convergent disorders. A lot of our patients are psychogenic. They are really hard to treat and handle. بس بالآخر إذا اقتنعوا, you build a rapport with them, it's so satisfactory. You see a patient who was suffering for years and nobody was fixing them, and then you are like their saver. They can walk now. Like convergent disorder could be like sometimes debilitating. The patient will be paralyzed for years, and now you save them, and now they can walk. So even like the psychiatric part of neurology is satisfactory, but I'd say it's more. It's not a lot of burnout, but it's more frustrating. You feel sorry for these patients. Like they are healthy, they are young, but like you can't do anything for them because like you don't have anything wrong physically, but yeah, it's hard. And sometimes we can do it, sometimes psychiatry do it, sometimes like yeah, you never find a solution for them. Yeah, but it's a very good question.
Yeah, thank you for the answer, Dr. It was a very rich perspective. Just to make sure from جوابك صح إنه specifically شغلة إنه ال day-to-day bread and butter cases إنه it is in general إنه خلينا نحكي a worse or less إنه palatable presentation, ولكن إنه it's a matter of perspective إنه as you progress as a physician it doesn't end up having that burden or tax or load. It's just a matter of perspective.
Yeah, and like I'd say, general neurology patients are also healthy. Like it's you are technically treating them. Like headache, tremor patients, simple epilepsy patients, you are curing them essentially. So if you're doing general neurology clinic, it's not like if you're not doing a subspecialty clinic, just the general neurology. Yeah, it's so satisfactory. Like maybe 10% of your patients will be very sick, but the rest will be happy and taking their daily medicine, and that's it. Similar to hypertension and diabetes patients.
Thank you very much,
محمد،
Dr.
أنا حابة أسأل بطريقة تانية بشبه سؤال محمد، بس إنه شو تأثير إنه الواحد يعني يعيش لحاله ويكون لحاله بالغربة وبعيد عن أهله؟ أنا عارفة إنه صعب، بس بدنا تحكي لنا يعني إنه أنت كيف حاسس، يعني كيف تأقلمت مثلا؟ إنه أنا حاسس البردن أنا عندي نفس perspective تبعك إنه toward المرضى، إنه حتى لو ساعدتهم شوي، حتى لو إنهم critically ill ومش راح إنك تشفيهم يعني، بس على الأقل خففت عليهم وحكيت معهم منيح بيكون بكفي، وعن جد هم they appreciate هذا الإشي كتير. فيعني حتى لو مرضى كان هيك بحس إنه يعني عادي إنه من ناحية أنت المرضى تحس إنه عم بتساعدهم، بس بحس إنه راح يكون الجزء الأصعب إنه أنا أتأقلم، إنه أوكي يعني الwork environment إذا كانت منيحة بتساعد، بس إنه كيف الواحد يعني هيك راح يقدر يكمل حياته وهو طول عمره مثلا عايش مع أهله وطول عمره معتمد عليهم وبيحكي معهم بقعد معهم. فأنت كيف كانت يعني خبرتك خلال السنة الأولى وخلال بعدين يعني؟
صراحة هاي يعني good question. صراحة it's hard يعني خصوصا الواحد إنه طول عمره عايش مع أهله ويجي United States و different culture, different people, different environment. I'd say at least بالكانساس ستيت Midwest people are nice. like الناس هم nice so welcoming. فهي الشغلة منيحة كانت. بالنسبة residency يعني خصوصا سنة أولى كثير بالنسبة لي first year intern كانت كثير سيئة. لأنه أولا intern year يعني هاي السنة كثير dense ويعني أكثر سنة هم بحرصوا عليك فيها. السنين اللي بعديها نعم بتناوب أنت، بس ما بتكون أنت يعني هيك يعني أقل واحد بالتيم الكل برمي عليك شغل. لا يعني بالسكند year أنت بتكون more senior role. Third or fourth year technically you're unattending even, like you are supervising people and like they are asking you. But the first year it's a new environment, new healthcare system. You are learning medicine, whole internal medicine from scratch. لأنه صراحة as a medical students ما عندنا كثير exposure to what's actually to work in the hospital. So you're learning how to work in the hospital. You're learning internal medicine, new culture, new system, and on top of that, the burden of first year, which is like all the work is on you. يعني ما بعرف. It was hard صراحة. first year كثير صعبة. first year كانت أعتقد هي كانت بتعتمد على الناس اللي حواليك. يعني أنا بالإنتاج ما كثير حبيت الوضع، بس بالنيورولوجي يعني second year so busy in neurology بس ما حسها كثير صعبة زي first year. yeah, I don't have a good answer on how to deal with that, but هي صعبة صراحة. يعني being by yourself with different environment, new healthcare system, different people, it's hard. و first year is the worst لأنه أنت أصلا يعني you are an intern, you are doing things كثير يعني ما بتعرف انت ما عم تتعامل معها، وكمان انت قاعد بتتعلم telemedicine انت عارف انه هي مش تخصصك مستقبل، يعني انت you are forced to learn it. بس عارف انه نعم هي شوي مهمه بين بس مش كثير. ف overall yeah I'd say first year of residency is really tough. The rest of residency is fine I think. Like so for a second year كانت شوي صعبة بس ما حسيت بهالبردن. Third year is a joke so far. Like most of my rotations بتداوم على 8 من 8 ل 5. Fourth year is even much easier. Most of it's outpatient. هي يعني I'd say first second year هم اللي كثير صعبات mainly first year.
تمام.
تمام شكرا.
في سؤال؟ لا في حد عنده سؤال؟
ليان كنت بدك تحكي شيء؟
لا بس كنت أحكي شكرا. هو أنا صراحة مش يعني أكيد الواحد ما راح يعرف غير لما يجرب. أنا حس مثلا الشهر يعني أصعب جزء فيه لما عن جد إنه بتكون بدك تحكي مع حدا بالعربي وتحكي الأشياء أنت متعود تحكيها مع أهلك وما تلاقيه، يعني هذا أصعب شيء. فبس هي هاي، وسبيشلي إذا ما كانش مع حدا يعني يعيش معه من أصحابه أو هيك. فبس كنت بدي أشوف يعني أنت كيف you adapted للإشي، بس إنه أكيد ما في جواب بتوقع غير إنه الواحد يجرب.
yeah I've not adapted yet. بس الشغلة يعني أتوقع المنيحة عنه هون إنه في شوي community منيحة عربية، في ناس بعرفهم أصحابي أصلا already ماشية تخصصات ثانية، والبروجرام عندنا يعني it's not super IMG friendly يعني، بس كل سنة بيكون في 1 or 2 IMGs وأغلبهم بيكون يا عرب يا هيك، فالواحد شوي يعني will develop a community بالتالي. أتوقع هاي الشغلة اللي اختلفت كمان second year compared to first year. يعني second year I صرت أعرف ناس كثير، صار عندي community. first year ما كنت أعرف حدا، فالواحد هو بتعود. plus if you spend a year يعني even your co-residents even حتى لو أمريكان they will become your family يعني بجد. يعني أنا أغلب الco-residents اللي معي حتى لو أمريكان حتى لو مش عرب أصحابي وبطلع معهم، ويعني فهي الشغل هيك الواحد يصير متعود.
تمام. في كمان حدا عنده سؤال؟ يمكن حدا من الرابعة أو شيء هيك حابين تسألوا شيء؟ ما حدا يستحي. أوكي ممتاز. يعطيك العافية دكتور محمد، شكرا إنك أعطيتنا هذا يعني very very focused discussion وكتير منيحة. أنا متأكد 100% إنه كتير منا كلنا إذا ما استفاد المعلومة استفاد المعلومتين. كتير انسايتس منيحة وحلوة والواحد ما بيقدر ياخدها من حدا يعني إلا ليكون مار فيها زيك يعني ما شاء الله. on behalf of يعني طبعا UG Sign نشكرك. بشكر أنا شخصيا كمان طبعا الأوفيسرز واللي سوى هاي الشغلة، ونتمنى لك التوفيق يعني we look forward to working with you again in the future إن شاء الله.
Alright, yeah, well, thank you for inviting me to talk here. وصراحة I'm so proud of you. يعني it's from a very early stage of your career, you're focused and dedicated. Keep it up. If you have any questions, you can maybe share my email. I'll send you my email and Facebook account.
Yes.
Yeah, hopefully I'll meet you more, like نعمل more sessions.